Hi, I'm Sean Mooney, professor at the University of Washington and Chief Research Information Officer of UW-Medicine. Over the past 2 years, we have been creating an initiative in medical data science, and as part of that, we have created this seminar. Speakers will include world-leading scientists who will tell us about how data can impact human health and their healthcare. Please use the link below to register for our mailing list to hear about future events in this series. We hope you enjoy them.
So today speaking, we have Dr. Judy Gichoya. She's an assistant professor at Emory University and works in the interventional radiology and informatics. Her career focus is on validating machine learning models for health in real clinical settings, exploring explainability, fairness, and a specific focus on how algorithms fail. She's heavily invested in training the next generation of data scientists through multiple high school programs, serving as the program director for radiology, AI training editorial board, and in charge of the machine learning elective at Emory University for second year and fourth year medical students. He's worked on the curation of data sets for the Society for Imaging Informatics in Medicine Hackathon and Machine Learning Committee. He volunteers on the ACR and RSNA machine learning committees to support the AI ecosystem to advance development and the use of AI in medicine.
Thank you and welcome, Dr. Gichoya. We're so excited to have you. I'm going to stop sharing my screen and let you take it away.
Thanks for the invitation. And let's get started here. So, I selected this topic around regulating AI bias, and the reason for this is because I feel like it's a good way to talk about what's hot in AI. It's not going to be comprehensive because this is such a changing field every day, and but hopefully this is going to give you some insight to be able to get more information and to even suggest how I can make this better. Some of my disclosure is that I'm not a lawyer, and so I'm not going to be a legal expert around these things, but I think it's an important area for us to be thinking about, because our work has an impact, downstream impact on how policy will be made, and more guardrails are required to be set up. So my disclosures are around mainly service and various forms of grant funding, and that's not going to be really biasing the talk. So when I think about AI regulation, I start off thinking about sort of what would be our current state or maybe recent past, and that would be around thinking about patient privacy and data sharing. Because, when we were able to implement electronic medical records systems, then most people were concerned, rightfully so, and it still remains a big concern about how do we share data, and I will show you the evolution of this, and also patient privacy. And so then we bring in AI, right? So initially it was just data, and then now we bring in AI, and then we have thinking about just regulation for performance. And I'm not going to spend too much time on this because it's actually quite a comprehensive topic and evolving. And what you just have to remember at that point is just the FDA. And then the next area that we're seeing just in the last couple of months is this suggestion that we should regulate AI to mitigate bias. And that's very, has quite a lot of implications, not just in healthcare, but in places, for example, policing and facial recognition, where we do know that existing systems do not work well for specific people, groups of people, and so it's going to be interesting to see how this evolves. And not to mention that, political changes, for example, like the being woke, or, saying that it's not, you shouldn't use disparities. So this is an evolving area, but we see quite a lot of legislation being proposed in this area. And then what's a talk without ChatGPT? And I would like to spend some time talking about just a futuristic view and thinking about AI regulation in this era of large language models or foundation models. And for that topic, I apologize in advance if you're on the call and I go to give my very, very basic explanation. Please bear with me. But I think if there are people on the call who don't understand just some of the big nuances, why is this different? It's going to be lost on them unless we think about this. And I hope that this is going to make for an interesting discussion thereafter. So when I say current status of regulating AI, which is what I said, EMR introduction, patient privacy, data sharing, then we did, it was really spun around electronic medical records. But if you think about sort of what would be the FANG or the big 5 tech companies, I think now NVIDIA would meet this criteria, is sort of like this data is the new oil, right? This is in 2017 on The Economist, and it's just saying, well, if you have data, and subsequently there are versions that have said, well, maybe if you have curated data, that's when you have the real oil. But we're back again because with these large language models, then it's extremely difficult to get access to large data sets. And this remains one of the intellectual property features that is not disclosed when it comes to training these LLMs. And so, we have 3 regulations really around patient access to medical records. And so the 2000 HIPAA privacy rule established an individual's right to access, inspect, and obtain a copy of their health records upon request from a covered healthcare provider. And so you can get penalties if you don't. And in radiology, it's even more important. There has been a big campaign of ditch the disc. If you have been a provider, being a patient, and your images are not in the same system, then you do know it's quite a hassle to just move your images from one healthcare institution to another for maybe even a second opinion. And but in 2009, from the early lessons of electronic medical records deployment, then the High-Tech Act directed HHS to adopt certification standards for EHRs, and so including again patient access and to create rules for patients who provide access under Medicare enhanced payment programs. And then in 2016, the Cures Act, and this then directs HHS to make sure that patient records can be exchanged by developing the trusted exchange framework and the common agreement, and also require certified health IT to publish APIs and to educate stakeholders about how health information can be exchanged to provide access, right? So it's just saying, look, we want to make sure that the use of technology actually saves patients' lives. And yeah, to be able to do that, we do need to certify you to meet this meaningful use criteria. And yeah, maybe this meaningful use is making us so closed off. And the big future is that we can be able to access, patients can be able to access data, and their providers are spread across multiple things. And so under HIPAA, again, the patients have a right to the electronic medical record and to have the provider transmit PHI, and you cannot charge them a ridiculous amount. And then CMS promoting interoperability program, and this is stage 3 requirements for providers, and requires that digital systems allow individuals to view online, download, and transmit their electronic health information. So if you've been to the doctor, then you know that they really just want you to use your patient portal. These are some of the drivers for this. And that you can access your choice of third-party health apps using APIs. And then the ONC, which maintains the certification, now offers certifications for API functions so that apps can retrieve whole or patient records. So this is important because with Cures Act today, when I sign my report, it's available to the patient immediately. And so this never used to be that way in the past, but I told you, right, you have penalties. And so if you're going to be penalized, you're not making a lot of money, then you're going to try to adhere to as much regulation as you can. And so this is important, especially for my fourth area objective, when I'll be discussing how these large language models and how their implications will be when we start to think about regulation. Because if I can get my document and I can get the data not in an anonymized fashion, then I can feed it to any large language model engine. I can copy paste them into ChatGPT. And what if I copy paste my EMR? In the past, you could say, well, Judy dozed off. She left, PHI printed patient notes on the bus station. And so you will penalize Judy and you'll penalize my institution. But at the same time, in this new era, or as we get into the large language models, then it's going to have some gray areas because you don't know, is it me who leaked the data or is it the patient who leaked the data or someone else? And so I mentioned the penalties. You can see they can go up to quite a lot of millions of dollars. And these are usually, doing business without business agreement, BAAs. So be very, very careful when you have new research partners and you're excited about them, how they access data. Right, so the institutions tend to be very risk averse for this. They think about, obviously just leaking PHI, not storing their information on encrypted drive. So if you have a mobile device, not a mobile device, but your laptop, and I just really encourage everyone to make sure that they're encrypted. And, the health hospital IT system usually is helpful, but maybe better not to have any PHI really on your local devices. And then, some others is, for example, not being able to provide patient their information when they requested it. And the other example provided is, for example, taking patient pictures without their explicit permission. So there's nothing, no better relationship to study this more than this partnership between Google DeepMind and health, and really AI which was meant to predict renal failure. And this opened access to the NHS data, broad access, not a specified cohort. I do know that this is quite a common mistake early vendors and institutions that were partnering together made, so that you're not really subsetting the data or the BAAs are too broad to really specify what was there. And it's a good paper to review, but one of the things is that when the public found out about this collaboration, and it wasn't they didn't feel that it was transparent, and that that the scope was too broad, and that the BAA, there wasn't sufficient coverage. For example, maybe I'm never going to get renal injury. Why would this algorithm affect me? But more importantly is that it was so broad that next week, if I decided to train a tool algorithm, that the BA would have covered it. And so today, when we think about the current status around patient privacy and data sharing, which is really how we think about the current regulations that exist, is these still remain the questions. And as I move forward, I want to challenge you to say, has this changed? Do we still have the same questions? And so the first one is, do we need consent for data sharing? And when and how do we get consent? So I've gone to the hospital and I get 8 papers to sign. I'm sick. I'm going to sign those papers because there's really not much of an option. Do we think that this is sufficient? How do patients opt out? And quite a lot of work has been done to empower IRBs to protect patient privacy, especially in the era of AI. And can we sufficiently de-identify our anonymized patients so that we can do their AI, you can apply AI algorithms on their data for training or for testing? And can patients opt out? Maybe they found out a few weeks later that maybe this is not what I really wanted. And what's this universal consent? For example, I may be okay using my vital signs, but maybe if I have bed sores, I don't want pictures of my body taken. And do we even have mechanisms to allow that? And the concept of who gets benefit, but also that there are new mandates, especially, if you're going to get money from the NIH, then you do need to share the data that you're using. And so how do we balance sort of these new demands and requirements which affect us? And so AI regulation, which is my second area for real world use, is really FDA and the process of FDA approval of software. So this is an area that is completely changing. And, I think over the years we've seen, well, FDA doesn't think that they need to approve any software now. They think, it's just an evolving area. And I think we will. We've seen recent changes, including that you can make adjustments to your software. So in the past, when you say, this is my working thing, if you went back to the real world setting and realized that there was quite a drop in performance, you couldn't come back and say, I'm going to fix this, but still have the same approval. You'd have to redo the approval process. So clearly not incentivizing people to fix problems. And we all know that that's usually when you get them in the real world marketplace more than you're testing. And so class 3 tend to be very, very strict. You can imagine an implantable pacemaker versus something low risk profile around maybe a Band-Aid or manual stethoscope. And so what tends to happen with FDA approved applications, there are over 500 approved right now, is that they come back and say, is there something similar that is in the market? Maybe there's a stroke algorithm, then they try and say, okay, I have, something that works the same way, and you show that the comparative nature or the effectiveness, and then you get your approval. And so the AI regulation to mitigate bias is something that is being proposed on existing regulation. Remember the 3 regulations that I showed you. And so there are many types of bias. This is a paper done by a really wonderful group that is looking at bias in a large collection of medical imaging data. This is called the MIDRIC data. It's a project by various radiology societies funded by the NIH. And, it's looking at, what are some, you can get bias at the level of data collection. For example, if you're missing some population, or, how you're sampling, if you're not going to share the whole data set, or, for example, you may have some at the point of acquisition and aggregation, or at the level of model development, or at model deployment. And some of these overlap. You could have, for example, population bias occur during data collection, model development, and model deployment. And so one thing that is now quite a lot in the forefront of everyone's mind is this automation bias. And I'll show you an example as I come to the end of my talk. And so this is a really good paper to serve as a refresher, and sort of showing that there's quite a lot of intersection. And the reason why I show this is that it's very, very difficult to agree on bias, and you almost always have to trade off. And, you're always saying, well, I can optimize for one thing versus another thing. But for example, you can have group fairness versus individual fairness. And even more so, what makes it challenging, and I'll show you in a few examples, is that people occur at intersection of groups. And this is important. For example, females may be more marginalized, but Black females versus Asian females versus white females are very different in their profiles. And so understanding, this intersection of bias across that people have different subgroups. It's not just one clean group. And yet we still want to analyze bias that way makes it very challenging. The second thing is that most of the techniques that are there for detecting bias are actually mathematical, right? So you're saying, I'm going to write a mathematical function to make sure that I reduce false positives or false negatives, depending on the metric that you decide. And so the challenge with this is that if you are optimizing for a mathematical function, so I raised an example I actually picked up from a book, is imagine a cookie, and you have 2 children, and they are fighting over the cookie, and finally they say, well, they split it, and one is just slightly bigger than the other, and it turns out that the other part of negotiation is that, well, maybe I'm going to choose the TV show that I'm going to get the lesser size of the cookie, but I'm going to also choose the TV show that we watch today. For those two children, then their perception is that it's fair, their system is fair, but there's no real mathematical function that you would be able to fit, without having an equal 50-50 precise split of the cookie. And so I like to use that to reflect that social circumstances and the context really can mean that something is fair, even if mathematically it's not really fitting a perfect line. And so that still remains very difficult. So recently we had a joint statement on enforcement efforts against discrimination and bias in automated systems. And this came from 4 federal agencies: the Bureau of Consumer Financial Protection, the Department of Justice, the Equal Employment Opportunity Commission, and the Federal Trade Commission. And, the FTC, I'm going to dive into a little deeper, but, people are saying, well, you can't really discriminate people because you use an algorithm to select your applicants, right? That there has been those cases, for example, Amazon hiring and how they found bias in the algorithm, or even when people say, well, I'm not going to supply a specific area because there's not enough money to support my prime delivery. And we know that these are real world cases, that those are not going to be tolerated. We know that in the context of policing and facial recognition, Black and brown faces are not well identified. And in the consumer financial protection, they want to make sure that, that there's safety and, especially all these algorithms that are around us, even in places that you don't anticipate. And so this was an opinion essay penned last month about from Lena Khan, who heads the FTC, and saying we must regulate AI, and here's how. But her big thing is that, look, the one other big revolution we've undergone is in the 2000s with the entry of the internet and these big companies. Now we have these big companies that are difficult to, that must, I'm pretty sure you've seen these calls to break these big companies down, break up these big companies because they can kill competition. For example, if I only want to serve advertisements for specific companies, and also that type of these big companies without competition limits innovation. And there is precedent. So the FTC provides these 2 examples. Corteva was selling data that tracks people at reproductive health clinics, places of worship, and other sensitive locations, and they were fined. And this was just being used to trace people and to identify people and trace their movement. And then Bell Labs, which is HP, and how they had to split the hardware and their software devices to be able, software and hardware division separately. And this spurred, they believe that this was one of the things that spurred some of the successes of the PCs that we all enjoy. And so I'm trying to make sure that we've learned from the mistakes of the past, and how these companies, you have just power concentrated in a few companies, is one of the FTC's call for this sort of, that we're not going to tolerate any bias. But like I mentioned, it's very difficult, even for people who work in this space, to really agree what's a fair algorithm. And so, from a medical perspective, just allow me to go down this way, is that, I talked about the ACA, the Affordable Care Act, which prohibits discrimination in health programs and activities. And you can get penalties, which you can be investigated by the Office of Civil Rights. You can be face suspension of your license or termination of federal assistance, and compensate and be made to pay compensatory damages. So, for example, in 2017, University of Connecticut was fined $20,000 for failed effective communication with deaf patients. And the thing about this is that you can have like a private right of action where an individual patient can sue you. But the proposed change actually saying, look, we want to prohibit use of discriminatory clinical algorithms in decision making. And so you cannot, this would be applicable to covered entities, but the entity may not be liable. So you can just loosely use this, for example, a hospital. It won't be liable if it did not develop the algorithm, but if it relies on a biased algorithm, then this is a problem. And it doesn't really specify that it has to be an AI algorithm. It just says an algorithm. So for example, if you have a GFR calculator or a pulse, oximetry based algorithm where we know that there's quite a difference in the performance, then you could be held liable. So, so it's, again, I mentioned that it's difficult and to assess bias, but this rule places the burden on physicians, and they say, well, you should consult frameworks, for example, the AMA framework that says, well, let's evaluate algorithms, develop protocols, and ensure meaningful oversight. I don't know if you've talked to just the usual random physician who's not interested in informatics, or, I mean, they don't have time to write their notes, do all this work, call the insurance, maybe the ChatGPT is going to help, but they don't even have the background to even understand this framework of, let alone assessing a model, but also assessing bias. And so, the best practice recommendation is that this, this rule proposes is to say, well, let's establish a safe harbor and, as a standard of care, and then coordinate with the FDA, which has a lot of work to develop a checklist. When every time you're stranded and you don't know what to do, you come up with a checklist or a standard, and this is going to mitigate bias. And then this is going to be shared to model developers and clinical users. And the blind spot here is really to overall rethink the approach, as instead of placing the burden on healthcare professionals, which I think, because I guess that's easy to penalize, but that's what's happening. And so here's an example of bias in radiology. So this is a very, very popular paper done by a friend of mine. And what they look at is chest x-rays. And they say, we want to look at normal chest x-rays. And so if you have a false positive prediction of no finding, so you have a false positive where the model says you have a normal chest x-ray, but it's a false positive, then it's missing a diagnosis for the patient. And so they call that underdiagnosis. And then, so they start to look at this intersection, for example, looking at sex and race. And they show, well, if you look at the false positive rates, the females, patients who are younger, you always, this data set doesn't really have a lot of young patients of 0 to 20 years, but Black patients and, Hispanic patients following closely, Medicaid patients, these patients tend to have their studies read as normal, but yet they have disease. And so, sorry, excuse me, I need to stop this. Sorry about that. And so if you look at these examples, then you start to say, well, what's the difference between black males versus Black females, or differences in ages? And it's that intersectionality that makes it very difficult to even apply the current methods of evaluating bias. And so this is an example, and this is the first one was showing the false positive rate, and this is the false negative rate. And so, but that's already, we find a challenge when we come to think about this sub-intersection of groups. But here's just a summary of a lot of paper. This takes me quite a lot of time to explain, but I've put the links of the papers down here. And it's this concept. So last year we published this work where we said, from a chest x-ray, I can tell you with AUC values of, 0.96, 0.94, that this x-ray is from an Asian patient, a patient who self-reports as Asian, Black, or white. And I can also tell you, after applying, these high pass and low pass filters, I like to explain that, for example, if you have a picture you're posting on TikTok and you apply filters to change the appearance, if you do the same for the chest x-ray, so you have this image here that is barely perceptible as a chest x-ray, then I can still tell you with an AUC of 0.86 that this came from a Black patient, and I cannot barely tell from a radiology, visual ability that this is even a chest x-ray. And then in a related study with Dr. Paros from Chicago, we start to look at, could AI just use the chest x-rays to predict some ICD codes? Because if you don't have an ICD code, then that's actually a disparity. And so when I come to that, then we start to also link this data with a social deprivation index. And so this is using the zip code level calculation of poverty. And so this looks at what's the level of education, what's the rate of crime, what's the income earning potential. And if you come from an area with a high SDI, you come from a very poor area versus a low area. So what does that mean in terms of predicting ICD codes and predicting SDIs? And we find actually good performance, at least better than the human being. And this was around 0.76. And so then this other work was done by the Stanford group, a group from Stanford, who trained 4 models to predict 1 year, 3 and 5 year expenses. And, some of these models, you can see they're using some poor proxies, for example, zip code that we know that can definitely carry a lot of information, but they use an imaging-based model only without any of the clinical features. And they show that, well, with AUCs of 0.75, I can tell you what the cost of the healthcare expenses are going to be for a patient at 1 year, 3 and 5 years. And then it's not unusual when you're opening up images of medical images, or even just going to a patient's room. These are just synthetic images generated from the internet. And you walk in and they say, oh, Judy, I say, oh, I'm 60 years, or you had your 60 years, and you walk in and I look 80 years, or the other way around. And so this concept of aging and understanding that we all age different, and there's genetic and social factors that have an impact on this, but to also this group here, what they did was to try and predict biologic aging just using chest x-rays. So essentially, from just a chest x-ray, without understanding the mechanism, I can say Judy is Black, lives in a poor area, has congestive heart failure and arrhythmias, is going to spend 15,000 in the next 5 years in healthcare, and her chest x-ray age is 60, her chronologic age is 40. She's aging much, much faster. Yet we cannot identify any of these characteristics, or even able to understand, is it a confounder, which we know causes a lot of model failure, or is it something real? And so why does this matter? How can you penalize or regulate bias in this context when you cannot even understand what hidden signals these models are able to pick up from our data sets or from something else that we are still working on? And so I show this, for example, just looking at some of the things that could end up affecting our radiology data sets. So there are not many data sets in radiology that have a lot of demographic information. Actually, we did some work here and reviewed them. They're less than 5%. And even the type of imaging, when you just present with the same symptom, everything the same, is different. So Black, Hispanic, and non-white patients are less likely to undergo diagnostic imaging in the emergency room. And then if you think about something like mammogram image quality is a potential contributor of disparities. And this is because if you have, for example, a bigger breast, or just because someone has to press your breast on the mammogram, and that affects the quality, and just those small human things and are stored in the images. But when we start to train and fine tune and try to get as much juice as we can from these models, these actually are things that can be perpetuated. How can you start to regulate for bias in these cases? And so in reaction to the to the JAMA paper that I showed you that shows the ACA changes, then there's quite a reaction that said, look, it's unfair for you to say to want to regulate, especially for equity, and this is going to hamper innovation. And so we wrote this opinion piece to show that selection decides where innovation occurs, or really money decides where innovation occurs. Look at something like facial recognition that we rely on. In fact, with our masks, we've been able to even have better facial recognition that you can open your iPhone just when you have a mask on. And so the Senate, the House Rule for Facial Recognition Act of 2019 failed to pass, and in June 2020 in the Senate, and just showing you the complexity and these state-by-state laws are what is defaulted to when it comes to some of these applications. And so you can think about that equitable deployment is not synonymous with equitable outcomes. And this is just trying to say that most of the impact actually comes post-deployment. For example, if you think about insulin, it wasn't meant to work better or worse for a specific population. So you could say that that was something that was not meant, built to work better for Black patients or white patients. But if you think about cost and the post innovation deployment, that the distribution is really the cause of inequity, as is happening to some of these newer injectable drugs for weight loss. And so this emphasis on real world deployment and understanding where models fail and innovation fails is really the most important. And my personal opinion is that instead of penalizing, then we should be incentivizing people to detect bias and mitigate it. And so my last area is to look at AI regulation in the era of large language models. And so, in the past, when I was talking about, oh, what's AI, I would say, well, it is AI, machine learning, deep learning. Not anymore. You just have to say, do you know about ChatGPT? And what it's done is that it's brought this concept of AI to the common the common person. And so what I mean by that is now we're seeing, for example, last month when we had a viral song, not sung by Drake, the rap artist, but his lyrics generated in the style of Drake and then fed into an automatic music generator, and the song went viral. And people, are like, wow, maybe that's a little too much, And so what they, the I don't want to say citizen, just sort of like the normal person who's now being a recipient of these technologies in their day-to-day life don't realize it's the same technologies or the same concept that is being pushed in medicine. And so these large language models, I'll just focus on text. They require a lot of text. So these are 5 sentences generated using ChatGPT. And they may, sometimes it's to say, well, we've always worked on text. And it's true, there has been many, many innovations. And some of these started just from a word and then moved to a sentence and then done to documents. But what's different with this is that there are 2 sort of innovations. If you have to look at a lot of text, then you need to know, and even some of the broad things would start from understanding a sentence from the left side moving to the right side. For example, this sentence, the animal didn't cross the street because it was too tired. And so you could wonder, does it refer to the animal or the street? And so in this case, in the past, at some point, you could only understand the subsequent part. And then we had bidirectional understanding of text. And this spurred what are some of these models called the BAT models. And then subsequently, with this work for attention is all you need, we had 2 innovations that it figured out that, well, we could understand forward and backward what area to pay attention to in terms of understanding relationship. And so we moved on from just understanding, for example, king is, related to queen and how to encode that, or big, bigger, biggest, something like that, to understand without irrespective of positioning, how much weight to place on words. And so to be able to do this type of thing, you still have to end up with zeros and ones and different type of encodings. Then we needed to be able to load the text data in parallel streams and be able to run them multiple times for computational efficiency. And so this was also important through the development of the transformers. And so I come back to this sentence where I showed these 5 sentences, and I think the best explanation I've seen for these large language models is fill in the blanks. So imagine that you had a sentence and you just kept randomly dropping words. So 2 things happen. Yes, you do need a lot of sentences to be able to train and also compute, but also that you already know the truth, because in this case, I know that I dropped the word surgeon, or in this case, it was patients or, medical professionals. And so if you keep dropping this and understanding what to pay attention to, then you can get a better understanding of the large language model. And so therefore, the amount of text and the parameters that are used to train these large language models, which are harmful for our environment, are a secret. And so only big companies with the type of resources have ability to train them. Now, there is quite a lot of innovation happening in the open source world, and I think it's going to be interesting to see how that evolves, because open source communities may not really have all the resources. And also because they're hungry to learn new things, then, it's not unusual that they will take your data to train the model. And so I want to tie this point to the Cures Act that allows you to just copy your data and put it to any chat agent and start interacting with the data. This was one example where the Samsung workers were leaking some of their code because they were using ChatGPT to help with the coding. And so this, is a challenge when it comes to healthcare. And then the third area is that these LLMs like to hallucinate. For example, here are my top most cited papers of Judy, and these are all fake papers, and they're actually put in a little bit of believable journals. It would not, I'm an interventional radiology, so this is an area in these three journals, these three articles in the same journal is a place that I would actually publish. And so what is really surprising is the believability, that if I didn't know my papers, then you may say these are possible. And I think some of you may have seen what happened to the lawyer who presented, I think 5 cases that were actually all hallucinated and no one could find them. And so when they are, being applied to healthcare, I like to start off here because Geoff Hinton, who recently quit Google in 2016, said we should stop training radiologists because AI is going to replace us. And now he's saying, well, I need to talk about AI. And so it's this, again, debate of how do we regulate something like this? We see quite a lot of people saying, let's stop this development. And I mean, interesting work. I would encourage you to look at the work of Timnit Gebru, whose type of voices are being shadowed, but these are the 2 researchers with Melanie who were fired from Google earlier on when they raised alarm from these large language models. And so, in medicine, we see this type of article. This is performance of ChatGPT, really on an USMLE-like questions and what this means. I think one this week I haven't read that has also passed the board exam for radiology. And one of these models is actually made by Google. It was just recently released, and the model trained on PubMed, which is where we get all our medical text, was just performing at 50%, so not passing the USMLE. The MedPalm version 1 just barely passed, and then 2 was increasing performance. And so during the 2, they released this data set, and this is the Med MCQA. And this is a multi-subject, multi-choice data set. And you can see which vitamin it comes from an animal source and how it's represented. And this is my big thing here is, do we think that this is sufficient for us? This is not even thinking about, but do you think this is a sufficient state of art for us to be using to understand these gains of the large language models for medicine? And usually you start off with the fill in the blanks about the world. And then you then come in and say, okay, here are 1,000 situations. And then you recruit physicians. In this case, they recruited physicians from 3 regions and say, okay, show us the question or, the prompt really, and then what's an appropriate answer. And then, so you fine tune the top, layer of them, of your foundation model with the fine-tuned answer. And so you can imagine, for example, if you train any of these 3 physicians about someone with fever, they may not really, maybe the physicians from India, but malaria may not be the topmost thing that they're thinking about. And so it's whose voice is in development is going to affect how these models perform. And then on the other hand, we see some of the adversarial testing, and these are the arguments of what people debated as what would be acceptable answers. And you can, if you keep testing these LLMs, you will see how they're changing every day. And so this paper was calling for that this is the future for medicine, that if you had multiple sources of data, just remember the fill in the blanks, right? If you can process it in a way that you can understand the relationship of the world, then finally you'll just be able to facilitate a guided exchange that would probably say, hey, show me the where osteophytes are, or show me, what's this lesion. And that way you would have this assistant. And so it's envisioning the work of the physician in a very, very different way. and so we're seeing quite a lot of work being done for chatbots and what's being appropriate or inappropriate in terms of completeness. This is an interesting paper that shows which answers are preferred, and the chatbot answers, again, this concept of believability, are thought to be more higher quality and more empathetic. And you can see this is just a simple question saying, can I die after swallowing a toothpick? And the chatbot response is very wordy, and this is from Reddit forum. So we also don't understand how this would be changing within a doctor's room. And this is not inaccurate, but what they realize even is when even the model is wrong, it says this really in such confidence. Actually, today a friend of mine showed me how a mental health group fired all their workers and replaced it with the chat, not a mental, it was substance abuse helpline, replaced their workers with a chatbot, and the advice was being incorrect and actually misleading. And so this AI generated advice now is being postulated that it's going to be seen in three angles. One is within the patient and physician relationship, where it augments, for example, someone like me. And the other one is patient-facing AI, where they are, for example, copying things, and then direct consumer health advice, for example, when, this was the thing, Coco, where they replace who is interacting with you behind the screen. And so it turns out that the only place where you could be liable is the first one, because you have the patient physician fiducial duty. And so we will see, I think, quite an interesting ability, especially with the outcome of this case from the lawyer. And so, ChatGPT can be used to simplify text. The reason why I put this here is that it's a little bit crazy and interesting, crazy in the sense of like, oh, maybe this is a little much, where you could say, well, write this report in the style of someone from rural South Carolina, because those types of sentiments are actually these assumptions we make about groups of people. And to be able to write that, I think it really has to remind us of the sentiments that the text reports carry. And we have, people have done work here where they're showing, well, how people are documented in the electronic medical records can tell you a lot about the person who, the identity of the person who's being recorded. And so in this era where we have a lot of patient access to medical records, it's going to remain a big challenge in this foundation model. This is, this doctor, I liked when, they describe how they tested. And this just shows you how difficult it is to understand what's the ability of this model. And what he did was went back and pulled 40 cases and then copied their history to ChatGPT and said, give me a differential diagnosis. And so there was a 50% success rate. And the worst performance was for a 21-year-old female with right lower quadrant pain, and could not come up with ectopic pregnancy, which was the diagnosis for this patient, and frequently misdiagnosed life-threatening conditions, but worked very well for classic presentation. So this may be why the models are able to pass this standardized exam. And we know that there has been calls to rethink how we train our future doctors. Should we make them data scientists, or what are the necessary competencies? There's quite a lot of, hope how this is going to save the doctor, so that they save pajama time, so that they don't go home and write notes. And I like to put this here for the effect of the medical scribes. They actually didn't have an improvement. Well, ChatGPT or whatever the next med GPT will be called is not going to get tired and can do this ambient listening. But when you look at how currently we understand how AI fails, this is the sepsis algorithm. It took actually, researchers, journalists to go back around 2 years to really study this model, how it was deployed, or how its performance was. But more importantly, this is a great summary by this journalist, which shows how this loose area of technology deployment, well, we're just a clinical decision support, we're not really an AI system per se, and how they get into the healthcare system. And as we have, see this ambient listening and as of present, really not having an area of regulation, I think we're going to really face a tough area for us to knowing how far behind regulation lies around innovation to understand how to safely use these systems in the healthcare system. And so I want to end with this. This is just telling you how much sentiment is recorded in the in people's notes, even if there are quite a lot of duplicated notes. And this is a focus group performed last year to listening to Black Californians. And the two things you find: minority patients are actually changing their behavior when they go to the healthcare system. They have these keywords that they say so that they can be heard. And the second thing is that how people are recorded. And so, for example, this one of the focus group participants said, "I feel like Black voices aren't as loud, they're not taken as seriously. I wasn't listened to, and it ended up being a very seriously life-threatening problem. I told my doctor I was short of breath, and he told me, you're out of shape, you need to lose weight and exercise more. It ended up being that I was severely anemic and had to have 2 blood transfusions." These are the type of things that our tech systems are, capturing, just as I explained in the section for the hidden signals. And we're also seeing a different errors. This is a new study published in Radiology that shows that when you give the wrong, and this is increasingly, there are several papers that show this, if you give the wrong advice to the radiologist or the doctor, you affect the performance of the best performing expert. And so it's, how do you penalize or how do you regulate where you lead the expert? And so how does this human machine partnership evolve to make sure that it's actually building AI that works for everyone? And so I went through what I think is going current past regulation in the context of patient privacy and data sharing. We then went to briefly just show that a chart of pathways for FDA approval for real-world use or real-world performance, and then dived a little bit into AI regulation to mitigate bias, introduced these large language models, and gave some of the areas that we see are challenging in terms of thinking about regulation. And again, apart from the same, in terms of the same questions are still, we have to think about them now. And I guess we now have to debate, do we need to stop training these large language models, as many of the godfathers of AI have called for? Thank you for the invitation, and I hope that this talk was helpful.